are proteins that regulate apoptosis, minimum BCL2, PAX. And so these are encoded by genes, and BCL2 controls apoptosis by balancing pre-apoptotic proteins اللي هم الباكس and PAC versus anti-apoptotic molecules BCL2. If you have a cell that has too much of BCL2, the result انه this cell has ability to avoid apoptosis. Okay. طيب لو تفتكروا الابoptosis is activated either by intrinsic or extrinsic pathway. Extrinsic pathway فاكرين الفاس ligand, and also there is also the caspases في النهاية اللي هي بتسوي الاكشن of apoptosis. Okay. So في انواع من الليمفوماز such as follicular lymphoma. So 85% of follicular lymphomas, they have mutation of BCL2, and what happens in these patients, the BCL2, which is located on chromosome 18, undergoes rearrangement with chromosome 14, which encodes for immunoglobulin. Okay, so result انه بيصير عندهم overproduction of BCL2, and so when the cells have too much BCL2 inside them, they are able to evade apoptosis. بمعنى انه السيل مش انه السيل proliferating fast، لكن السيل بتقعد تعيش اكثر من عمرها اللي هي مفروض تعيشه. اوكي، فلك ان تخيل مثلا الكره الارضيه، لو نحن في الكره الارضيه ما في احد يموت، ايش اللي حيحصل؟ الو. Okay, so if we are living in this planet and people are not dying, what will happen? أنا ماني سامع أحد حقيقة، بس لو أحد بيكتب في الروم I'm more than okay with that. Okay. Okay, anyways, so let's go on. Okay, mechanism of apoptosis in BCL2. So this is the extrinsic pathway. This is intrinsic pathway. BCL2 has a role in apoptosis, and so the other ability is limitless replicative potential. Diamond cells undergo senescence after and stop replicating after a certain number of divisions. كل cell is able to divide and divide again and again for 60 to 70 times, and this is controlled by many genes. One of these is the telomere. So what happens, as cells progressively divide, the telomere becomes shorter and shorter. However, some of these cancer genes, they have an enzyme called telomerase. So with each division, the telomere length will stay long, and so the cell is able to keep on dividing again and again. Sustained angiogenesis, طبعا tumor cells cannot grow or get to a significant size to be able to invade and metastasize and survive without vascular compartment, without vasculature, without blood vessels giving them oxygen and nutrients, and this is maintained mainly by vascular endothelial growth factor. Ability to invade and metastasize. So there are 3 steps of invasion and metastasis. First step, invasion of extracellular matrix, and then vascular dissemination, and then homing of tumor cells. Okay, and so this is what happens. So there is loosening of intercellular junction, and then for second, the cancer cell attaches to starts to degrade, releases growth factors locally that allows motility of the cancer cell, and then it also releases substances that break down type 4 collagen. This step is very important لانها هي اللي بتسمح للكانسر سيل انه الكانسر يتحول من كارسينوما انسايتو لانفيسيف كارسينوما. Why? Because if it has to go through the basement membrane to reach the lymphatics and the blood vessels. Vascular dissemination and homing of tumor cell. I will leave this for you to read on your own, but this is mainly mediated through chemokines and chemokine receptors. And certain types of tumor have propensity to go to certain body sites more than others. Like in generally, we have to remember that carcinomas prefer traveling by lymphatics, while sarcomas prefer traveling by blood. نيجي بعد كده genomic instability. Genomic instability is a cell when our cells are surviving in our bodies, they will undergo continuous events, and these events will lead to accumulation of mutations. In the normal cell, there should be DNA repair mechanisms, okay, which repair these damage. So the more chromosomal abnormalities or genetic abnormalities that accumulate in the cell, the more the cell becomes genomically unstable. So individuals with inherited defects in DNA repair genes, such as BRCA1, BRCA2, hereditary non-polyposis, colorectal cancer, xeroderma pigmentosum, have a defect in their inability to repair DNA damage by time their genome becomes unstable. Okay. Each cancer must result from accumulation of multiple mutations. So cancer is a process that does not occur overnight, but it's a process that's cumulative and progressive over time that requires multiple steps to reach the end, which is formation of a tumor. Okay, karyotypic changes or chromosomal abnormalities. So genetic damage during carcinogenesis may be either small, هذول نسميهم point mutations, or they are large and involve parts of chromosome that can be detected on karyotype. Common types of structural abnormalities in tumor cells are either لما تكلمنا عن genetics تكلمنا على types of genetic abnormalities, so you can refer back to that. Karyotypic changes in tumor can be either balance translocation, على سبيل المثال البيركت ليمفوما والفوليكولر ليمفوما، بمعنى انه genetic material راح من جزء من الكروموسوم ومقابله the same amount genetic material went back to the other side. أو إنه بيكون deletions in which segments of the gene or chromosome are removed. أو بيكون amplification such as اتكلمنا أول على ال HER2 gene HER2 receptor amplification. اتكلمنا أول also على transcription factor أو اللي هو ال NMEK. أو بيكون aneuploidy. So aneuploidy تكلمنا على aneuploidy قبل كده لما قلنا more than 2 sets of chromosomes, so not multiples of 23. هذا المثال على الفيلادلفيا chromosome. So this is normal chromosome هنا, and so you have this part which contains the ABL gene. The ABL gene moves from chromosome 9 to chromosome 22. And then from chromosome 22, you have this BCR locus here, okay, that will receive the ABL, and the result is this fusion. شوف كيف صار. يعني chromosome 22 صار أصغر شوية. This small chromosome we call it Philadelphia chromosome. لأنه ما they describe this in Philadelphia in the US. هنا نيجي لل NMEK amplification. So we can detect. We can detect these abnormalities by doing fluorescent in situ hybridization to see these regions of amplification. Okay. Right, lecture 5. So tumor immunity. So tumor cells have 2 types of surface antigen. Either TTA, tumor-associated antigen, which is present in tumor cell and normal cell, or TSA, tumor specific antigen, which is present only on tumor cell. So this is what we think. لكن بعض الأوقات what we think إنه is TSA and is only expressed on tumor cell can also be expressed on normal cell. فعشان كده ما هو accurate this definition، لكن نحن this definition is very important for us لأنه it can help us in number one diagnosing tumors, because elevation of certain tumor specific antigens might indicate to certain type of tumor or another, and also in addition to that targeted therapy. So different classes of tumor antigen can be either product of the oncogen or overexpressed normal cellular gene or oncofetal antigens such as alpha fetoprotein or altered surface glycoprotein or cell type specific antigens. Okay? So these are the examples here, and these are important now because now we are experiencing a new type, also breakthrough in cancer treatment. So now we have access to immunotherapy. We are able to modulate these immune cells to become activated against the cancer cell. And so what they discovered is that certain types of cancer cell are able to induce an energy in CD8 cytotoxic T lymphocyte. So the cytotoxic T lymphocyte are not able to recognize them as enemy. And so the immune system will not attack these cancer cells. So now we are able to design molecules that will attach to receptors on the cytotoxic T lymphocyte, and they will, such as PDL1, for example, and make the cytotoxic T lymphocyte activated and attack the cancer cell. Okay, this is actual treatment that's being used. Okay, so we talked about these mechanisms. The other mechanism is so I mean I want to talk about these mechanisms in detail, but I just give you highlights on what are the certain types of antigens that can be expressed on the tumor cell. So the modern classification of tumor antigen is based on the product of the oncogen or the overexpressed normal cellular genes such as tyrosinase in melanoma, or oncofetal antigens such as alpha fetoprotein or carcinoembryonic antigen, altered surface glycoproteins such as MAP1 and CA125. طبعا هذه ما هي كلها specific للcancer cell. They can also be seen on normal cells. Okay. طيب number 5 we talk about cell specific type differentiation اللي هي lineage markers. These are important in diagnosis and in treatment لأنه certain markers such as CD20 is specific for B cell lymphocytes and B cell lymphoma. Okay, and they can also be targets for drugs such as rituximab. Okay. طيب, immune surveillance. So immune surveillance, when you talk about immune surveillance, you talk about the immune system's actions on the cancer cell. So the immune system is able to recognize tumor cell as non-self and able to destroy them. في نفس الوقت the cancer cells have the ability to avoid the immune system and hide from the immune system. Okay. So it's mainly mediated by cell-mediated mechanisms, CD8 T lymphocytes, and also parts of the natural innate immune system such as natural killer cell and macrophage. Okay. So ايش الدليل انه immune surveillance مهم في الكانسر؟ انه we notice that patients who have immunodeficiency, whether due to transplant or due to HIV, tend to have more frequent and more rare types of malignancies. Okay, so the immune system is important. Okay, so how does the cancer cell evade the immune surveillance? إنها أول شيء تحاول إنه تكون الكانسر سيلز اللي ناجا. افتكروا اول تكلمنا على التيومر heterogeneity. So do you know what is tumor heterogeneity? Okay, so do you know what is tumor heterogeneity? So what is tumor heterogeneity? Okay, so there is something called tumor progression and tumor heterogeneity. So tumor progression is that the longer the tumor survives, the more able for it to become more capable and having different capabilities. So كلون عنده الابيليتي to proliferate fast، في كلون عنده الابيليتي انه ما يطلع antigens على السيرفيس. So these types of clones, when they are favored to grow, selectively favored to grow, they are able to evade the immune system. Okay, so this is selective outgrowth of an antigen negative variant. Okay, عشان كده هذه واحدة من الأسباب إنه لما يعطوا chemotherapy for cancer cell, they give more than one type of chemotherapy and also give it over a period of time in cycles. Okay, so the other mechanism is loss or reduced expression of histocompatibility molecule such as class 1. تعرفوا ليش؟ لانه ال HLA class 1 هذه اللي بتستخدمها السيتوتوكسيك T lymphocyte to be able to recognize this cell as foreign or self. Okay, the third mechanism is immunosuppression. Cancer cells are able to produce certain oncoproteins that have immunosuppressive abilities. Also, in addition to that, the treatments that are given to the patients as chemotherapy and radiation also have the ability to suppress the immune system. Okay, so what are the effects of tumor on the host? Benign malignant neoplasm may cause problems. البروبلم الأولى related to the location and pressure. وهذه ممكن تحصل بالبناين وبالمalignant tumor. So one can get a benign tumor in the brain, but in a strategic location that can cause death, for example. Okay, so is the reason why drugs that are used for cancer patients once don't work when they get cancer again? Yes, that's true. That's a good question, as a matter of fact. That's one of the reasons, that because cancer cells develop resistance. They are a living cell, so it's able to adapt, and so that's one of, as you mentioned, true. That's one of the reasons why chemotherapy, once the cancer recurred, does not work as well as when it was first diagnosed. So effective tumor on the host, effects related to location and pressure, also functional activity, especially in tumors that produce hormones. For example, tumors of the adrenocortical gland that produce steroid, you will have Cushing syndrome. It can also cause ulceration, bleeding, and secondary infection. Sometimes if the tumor causes rupture or infarction of an organ, for example, testicular tumor undergoing, or ovarian tumor undergoing torsion. تعرف ايش معنى torsion؟ torsion يعني زي لما تعرف لما تربط
خرج الدكتور ولا ايش؟ اوكي والله heterogeneity يا حبيبي. يلا باي.
Stop that functional activity, hormone production, also ulceration with bleeding and secondary. Undergo torsion. torsion بمعنى انها تدور في circular motion around its blood supply. So, what can happen is that due to the mass effect of the tumor, the organ will rotate and the blood supply will be compromised. And so, what will happen when you have compromise of the blood supply? You will have infarction. Okay. The other thing is cancer cachexia, because cancer can elaborate cytokines, can elaborate growth factors, and the inflammatory cells will also elaborate cytokines such as macrophages will elaborate tissue necrotic factor alpha and interleukin 1 and resulting in tumor cachexia. Paraneoplastic syndrome. So, what is paraneoplastic syndrome? So, it is a clinical syndrome that's defined by a set of clinical features that occur due to products secreted by the hormone, not related to direct pressure or mechanical effect or invasion by tumor. Okay. فالإفكت بتحصل لأنه التيومر cells are able to elaborate sometimes certain growth factor, certain hormone like proteins, and these will have clinical effects. These clinical effects, we call them paraneoplastic syndrome. And we'll talk about ما مطلوب منكم تحفظوا كل paraneoplastic syndromes. However, there are important ones you have to know about. I will be talking about these. Okay. Okay. Yeah, so paraneoplastic syndrome defined by symptom complexes that occur in patients with cancer and that cannot be readily explained by local or distant spread of the tumor and the result from elaboration of hormones appropriate for the tumor type. بمعنى انت هتسالني سؤال الان تقول لي طيب ليش ما اعتبر مثلا الادرينوكورتيكال ادينوما that produces corticosteroids paraneoplastic syndrome لانه الكورتيكال ادينوما اللي تحصل في الادرينال كورتكس الابروبريت تايب اوف هرمون في المكان اللي هي فيه اللي هو الكورتيكوستيرويدز right. So لكن however if I have another tumor let's say in the lung and such as a small cell carcinoma of the lung and it produces a protein or a peptide that has effects similar to corticosteroids and causes Cushing syndrome. لا هنا الآن في هذا الوقت حسميها paraneoplastic syndrome. So paraneoplastic syndromes are important. Why? Because they occur in 10 to 15% of malignant diseases. Sometimes they are the first presentation of an occult neoplasm. So they get the patient investigated for underlying cause of a certain syndrome, and the end is that this syndrome is caused by a tumor. So you always have to think about malignancy or tumors as a part of unexplained clinical manifestations of various syndromes. So they can be lethal sometimes. They are common in lung, breast carcinoma, and hematological malignancies. The most common ones are hypercalcemia, especially with small cell carcinoma, Cushing syndrome with hypercalcemia common in small cell carcinoma and more common even in squamous cell carcinoma of the lung. Cushing syndrome also can occur with small cell carcinoma and non-bacterial thrombotic endocarditis, which are caused by ectopic production and secretion of peptides. So we finished paraneoplastic syndrome. We talk about grading and staging of tumor. So very important to grade and stage tumor. Why? Because they can predict how will the tumor behave and also for deciding treatment protocol. Staging is the most important a prognostic parameter in most types of tumor. So we need methods to quantify the grade and the stage. Generally, the grade of the cancer is based on the microscopic features under the microscope, and we base that on how well the tumor cells are differentiated. When we say differentiated, we mean how much they resemble their normal counterparts. And also, we use sometimes the number of mitoses and others. But these are generally the two types of parameters we use for grading. So, in many types of tumor, you will see that we have numerical system ranging from grade 1 to grade 2 to grade 2 and to grade 3 to grade 4. So when we say grade 1, we mean low grade, and these are well differentiated tumors. When we say grade 2, we mean moderately differentiated. Okay. Grade 2 to 3, we mean poorly differentiated. Grade 4, we mean undifferentiated or anaplastic. So when you think about grade, you think about it like a spectrum. Okay. So there is no definitive cut line between, let's say, well differentiated and moderately differentiated, or moderate to poorly differentiated. But the difference between well differentiated and poorly differentiated should be obvious. So both ends of the spectrum, it's easy to decide if a tumor is grade 1 versus grade 3 or 4. But when you come to grade 2 and 3, there is a bit of subjectivity here, depending on the pathologist looking at the slide. Okay. So grading and staging, what system we use? We use the AJCC, the American Joint Commission for Cancer, and they update their system based on data, based on evidence. So there is an update every 1 or 2 years. For staging, we use, in the AJCC, we use TNM system. So T refers to the tumor, N refers to lymph nodes, and M presence of metastasis. فالT هيعتمد على size of the lesion. N depends on whether lymph nodes are involved and how many lymph nodes are involved. And M either will be M0 or M1. طيب ليش مهم أنا أعرف ال TNM staging؟ لأنه someone who presents with late stage of cancer may not benefit from aggressive treatment. However, someone who presents with early cancer might benefit. So how will I decide? Okay, so I have to use a system. And also, when you want to compare results between patients in different institutes, you want to know if your treatment is working as well, or you need to improve on it. When you compare it to a different institute, you need to use a system, a common system that you all agree on. Okay. Third, when you have a trial or a study, you have to know the staging of the patient, so you can know where your intervention or treatment is useful. Okay, maybe not all patients will benefit from certain treatment, and certain treatment might be harmful to some patients. Okay, without giving them any advantage. So this is staging. So staging is the extent of the cancer. Okay, staging is the extent of the cancer. Grading is how much the cancer resembles normal tissue. So grading is based on clinical, radiological, and surgical assessment, and also pathological evaluation. There is a pathological staging system. Okay, staging has more significance for prognosis and is the most important prognostic parameter in most types of tumor. Okay, grading is done by the pathologist by looking at the microscope and evaluating the appearance of the tumor. Okay, so grading is mainly pathological. So we talked about already about the AJCC system. We talked about the TNM system, and then so we put these TNM data into stages. So there is stage 1, there is stage 2 and 3, and there is stage 4. Stage 1 is that the tumor is local, okay? So it's local to the primary site. It has not metastasized to the lymph node. It has not metastasized remotely to other body parts. While stage 2 and 3 are in between. Stage 4 is, it means that the tumor is in late stage. Late stage means that it has metastasized distantly, okay? And so that's important to know in editing. So laboratory diagnosis of tumor, we use different methods. We use morphological methods by looking at biopsies, fine needle aspiration, cytology, cytological smear, or frozen section. So the tissue is obtained from the tumor and it's examined by the pathologist under the microscope, and then a report is issued. Or we use tumor markers, in which we do biochemical assay of tumor-associated proteins and hormones in the blood or serum. Okay, so why do we use tumor markers? So tumor markers are not mainly used for diagnosis. Diagnosis is based on clinical and radiological and pathological features. Tumor markers are used mainly to monitor treatment response, and in some type of tumors also part of the workup for proper staging of the tumor. Okay, we use also molecular diagnosis to identify the molecular abnormalities we already talked about, such as identification of mutations in oncogenes or tumor suppressor genes, or genes related to apoptosis. And also currently we can also do evaluation of immune cells within the tumor environment, okay, such as the PD-L1 I talked about already. Why is molecular diagnosis significant? So number one, diagnosis. It can help in the diagnosis or confirming the diagnosis, especially with particular tumors that have characteristic abnormality. Also to predict prognosis and behavior, and an example of that is HER2-neu in breast carcinoma, which is predictive and prognostic. When you hear the oncologist say predictive and prognostic, predictive means it's able to predict the response to treatment. So patients who have HER2-neu positive breast cancer are more likely to respond to treatments such as trotuzumab. So this is predictive. Prognostic means that these tumors that have this certain abnormalities might either behave better or worse than those that don't have the abnormality. So this is a prognostic. This is prognosis. Okay. Detection of minimal residual disease, especially in leukemia, because sometimes, hello? Because sometimes it is very important to ensure that there are no residual cancer cells within bone marrow, and we can identify minimal residual disease or by identifying their genetic material in the bone marrow. Detection of hereditary predisposition to cancer, important also in studying patients who have BRCA mutations. Why? Because these patients might respond to certain treatments, and also you need to screen the relatives or family members to detect cancer early if it occurs, and to treat early and prevent complications. So what are the methods we do use for molecular diagnostics? We use PCR, which stands for polymerase chain reaction. We use FISH, which is fluorescent in situ hybridization, and we use genetic profiling. And so that's it. Thank you very much. Ramadan Mubarak عليكم. إن شاء الله تكونوا استفدتوا. حاولت إنه يكون الشرح وافي بحيث إنكم تفهموا الكونتنت. حتى لو صار إنه ما اختبرتوا في الماتيريال هذه, just at least listening to the discussion You will remember this later on when you do your medicine rotation or oncology rotation, without being puzzled or bewildered by hearing of these terminologies. You can always ask questions related to the material or any other question that I can help you with within my area of expertise. And thank you very much. So, any questions? I think we're done.